So welcome to the Brain Development Podcast, and we're here to show parents there is a pathway to healing the behavioural and learning symptoms of their neurodiverse child. And my purpose is to help empower parents to understand how they can build their child's brain from the bottom up to invoke change. And today we have the incredible Dr. Michael Trayford from Apex Brain Centres, and I'm very emotional about today because to actually get you onto this podcast has been difficult because you run a very busy clinic. But Dr. Michael Trayford is a board-certified chiropractic neurologist and neurofeedback specialist and the founder of Apex Brain Centre in the US with over 2 decades of experience. And Dr. Trayford's renowned for his commitment to helping people build better brains, live a better life. And what makes your work so compelling is this unique and comprehensive approach at the Apex Brain Centre. So it's not just about chasing the symptoms, it's really delving into the root causes of the neurological and cognitive changes associated with all of those neurological, physical, cognitive, and metabolic rehabilitation. And it would be incredible at some other point to delve into QEEG scans and brainwave activity. Maybe we could touch upon that. But where I would really love to start is the patients that you work with day to day. Tell me a bit about the neurological challenges that they're facing and some of the root causes that you see that you can really help with, and how you then take them on that journey. I'd love to understand a bit more.
Certainly, yeah. Thank you for having me on. It's a pleasure to see you. I know we've had a lot of conversation. It's good to see you in person, face to face. So our patients, we have 3 primary areas of admission, and that would be traumatic and acquired brain injury, adulthood learning behavioral issues, and when I say adulthood, we're talking cognitive age level of, say, 10, 11, 12 or higher, and cognitive impairment. So we are seeing a lot of neurodivergence, typically related to traumatic and acquired brain injury, although I have over the last 15 years or so, worked very heavily with people in the mental health community. So from counselors to PhD psychologists, psychiatrists, etc., really trying to bridge the gap between the mental health sciences and the neurosciences. They rarely get together and communicate, which is mind-boggling to me because they're 2 professions that need to communicate more than any other. But we've really tried to make it our mission to bridge that divide and really just understand the neurological underpinnings. You talked about root cause, and a lot of people use that word. It's kind of like, holistic or green, or you hear these buzzwords, but we really try to stay true to those principles of getting to root cause. We fancy ourselves neurological foundation builders, essentially. When we work with somebody in the mental health arena, we hear very often from them that their job becomes easier when we do the work that we can do. So I always use the analogy, it's kind of like, building a house. You can't just build a house on the ground. You have to, cut the foundation, you have to cut the space out. You have to put in the forms, pour in the concrete, shore up the foundation, and then you can build the house on top of that. And often that is overlooked, and there's a lot of therapies just thrown at people to see what sticks, so to speak, all with the best of intentions. But if you don't have proper neural communication, if you don't have proper brain networking, if you don't have proper power output of the brain, things that we'll talk about, all your delta, theta, alpha, beta, gamma, all these different brain waves that tell us about the power output of your brain, if these things aren't working well, or they're not coordinated, or they're not organized appropriately, then there's really just only so much improvement that you can have. So yes, we are root cause specialists and neurological foundation specialists, and we really just want to understand through all phases of diagnostic testing, including EEG, what we can do to shore up all of these critical systems that feed the brain information, that allow the brain to communicate, develop, organize appropriately so that the brain can do what it was designed to do. And that's a pretty cool thing, because we may work very heavily with someone, say, with obsessive-compulsive behaviors or generalized anxiety disorder, whether related to a brain injury or not. And, when we start to work physically with these people, dealing with sensory integration, primitive reflex remediation, all of the things, then we can start to see the brain just kind of run with that. And oftentimes, people are being put into cognitive and behavioral therapy and all kinds of, cognitive and mental health therapies, and only getting so far.
Yeah.
But when we do those things, they can get much, much further, and those therapies just become all the more powerful. And it's from a relationship building standpoint too, because a lot of people live in their silos, and healthcare is pretty fractured and fragmented. So it allows us to communicate with other providers and develop referral relationships with other providers. So not just from a patient perspective, an outcomes perspective, but also too from a practice building perspective. Really we try to make as many relationships and get people to understand what we're doing as well, so that we can kind of feed off of each other.
So when you have done those diagnostics and you understand the areas of the brain that you need to focus in on, obviously you start at the foundation with primitive reflexes, sensory integration, getting enough ATP energy into the body, into the brain. What do you use? What are the tools that you use to help you do that?
Sure. It all starts with the history. I learned early on when I was interviewing practitioners of all different kinds, from, traditional medical model to alternative and complementary providers. When I was in school and before school, I just really wanted to know what I was getting into and what made people really good at what they do. And frankly, talking with providers that had very good track records and success rates, and and people just liked them, and they had these practices that you couldn't get into for a long time because they were so good at what they did. The one common denominator was talking with people, really taking a thorough history, just spending whatever time is needed to dig through all the things, turn over all the stones, and find out what was going on with that person. Not just their symptoms, symptoms are symptoms, but everything around it, diet, exercise, stress management, lifestyle habits, parenting, caregiver relations, things like that. So important. So it all starts with the history, by far the most important part. Then we get into the head-to-toe neurological evaluations, so all cranial nerve, cerebellar functions, looking at different lobes of the brain. We get into some rudimentary eye movement testing, which we look at further, with some things that I'll talk about. But neurological examination is critical. Francis DeMeyer, if you have DeMeyer's examination book, he's a brilliant neurologist that put together one of the best books on neurological differential diagnosis and examination techniques. And really, he said once that if you just look at how somebody walks, you can learn more about their nervous system than any other test. There's so much to that, looking how somebody carries themselves. If they can carry themselves while doing cognitive tasks, physical and cognitive go hand in hand, and you can learn a lot about somebody by something as simple as walking. So there's that. Then we get into the EEG. We're looking at electrical output of the brain, power output of the brain, lots of different things we can dig into data-wise there that we'll talk about. QEEG, S-Loretta imaging. S-Loretta imaging is just a little bit more advanced above QEEG, QEEG is the brain maps that people hear about. S-Loretta imaging is low-resolution electromagnetic tomography, which uses raw EEG data and real-time comparison to the normative databases, or even brain injury-specific databases that we now have, and there's learning disability databases. So we can see where those people stack up compared to their peers. But with S-Loretta imaging, we can get below the cortex, so we can start seeing what's happening in other regions of the brain, not just this kind of generalized cortical output. Cognitive testing, critically important. So we go through all the cognitive domains of simple, complex, and sustained attention, different types of memory, executive function, cognitive flexibility. We may talk about OCD and things like that. And if you have somebody who's cognitively inflexible or can't inhibit impulses, we need to look at that. We need to measure that. Then we get into the physical biomarkers, things like video oculography, so looking at eye movements, quantification of eye movements. Whenever we look at these studies or review them with people, we just tell them, Google eye movements and behavior, and you will learn, you will find so much information talking about stuff that is never put into practice, except for the functional neurology world and behavioral optometry and things like that. Your typical optometrist is looking at visual acuity, not oculomotor function, but oculomotor function is heavily tied into our higher cognitive processes. So we will see breakdown in autism, in OCD, in dissociative types of situations. So the eye movement's critically important. We look at balance and vestibular functions, quantification of those. I tell people all the time as well, just Google balance and cognition, and you will understand how the physical and cognitive go hand in hand. We get into interactive metronome is a tool that many providers use in this realm. I've been using that tool for 23, 24 years now. Never ceases to amaze me the power and its simplicity and in its ability to quantify attention, focus, impulse control, self-regulation. I talk about those four things all the time together because attention, focus, impulse control, and self-regulation are, in fact, the same thing as far as the brain is concerned. So if you teach somebody or train somebody how to have better attention, you will help them better regulate emotional output. It just goes with the territory. And then, there's other diagnostics we can get into, but those are the primary ones that we use. And laboratory analysis for sure, which is a big thing I left off, but you talked about ATP fuel delivery. We can look at everything from gut-brain axis to neurotransmitters and hormones to, the thing that a lot of people are talking about now, viral influences on everything from autism to cancer.
Yeah.
So lots we can look at there.
Yeah, some of those labs are pretty special in terms of what they can really give insights into. And then you start testing the parents and they have the same viral constitution. So tell me a bit about, once you've gone through that whole exam, what do you do next? What's the program that you put patients through in order to, let's just say OCD or anxiety, huge amounts of anxiety? How do you then take them through a program to help them? Do they do an intensive with you? Do they come back on a regular weekly basis, or is it every day? How do you really make a difference and get to that root cause and really build those foundations in strong?
Sure, yeah. About 15, maybe 14 years ago, we switched to a primarily intensive model. So we don't dabble in intensives. That's pretty much all we do. And really it's, sifting through some of the literature, going back with physical therapists and occupational therapists, working with things like traumatic brain injury, Down syndrome, CP, et cetera. They were working with these people 6, 7, 8, 9, 10 hours a day. Day after day for short periods of time, and the results were phenomenal. But, as we know, managed care came to town late 70s, early 80s, and really started to talk about this model of, 3 times a week, 2 times a week, 1 time a week. And, just if you just understand the concept of neuroplasticity, it tells you everything is wrong with that because you have to do things over and over and over again. I liken it to, I tell people all the time, if you ever went to a camp or you have a kid that went to a soccer camp, a music camp, they learn more in those 5 days than they did the entire year prior simply because of the immersion. So immersion is key for us, and that's where we see our best outcomes for sure. So it really consists of physical, neurological, cognitive, metabolic, and even getting into the lifestyle rehabilitation. So that could be everything we're looking at diagnostically. We have methods of intervention to help drive things in the right direction. So we're just looking for improvements in all of the things that we're seeing diagnostically. And that could be, from a neurological and physical rehabilitation standpoint. That's all the things like eye movements, balance and vestibular functions, complex motor skills, motor timing mechanisms. Then we have the, supportive modalities, different types of electrical stimulation for brainstem neuromodulation, for transcranial work, activation of certain areas of the cortex with things like TDCS, TACS. electromagnetic stimulation, neurofeedback, transcranial laser therapies. We do a lot of laser therapy, have been for a long time. So there's just so many applications depending on what the situation is. So the applications largely are the same from person to person. It's just how we implement them that is a little bit different. That's, how the recipe changes, so to speak, from person to person based on what we're seeing from them subjectively, objectively, and diagnostically.
Oh, that's amazing. And going back to understanding brainwaves, it would be great if you could give myself and the listeners a lesson in what you're really looking for in brainwaves. And when you do those diagnostics with, a QEEG, what do you really see within there that you can then understand that is dysregulated from a normal brain, and then how do you then take that into the whole treatment plan? How do you use that? It'd be lovely. Well, I'd be really, really interested to go through, what each of those waves actually do, and the cycle of those waves throughout the day.
Absolutely. Yeah. So, there, it's, just to kind of preface, EEG, learning EEG for the past probably 15 plus years, it's been one of the best things I've ever done. It's one of the greatest learning curves I've ever experienced, but one of the best things I've ever done. And it doesn't have to be overwhelming and difficult. And I'll say all the time, and I've done a lot of talks on this, that so many practitioners in the functional neurology world, in fact, most of them do not utilize EEG. And in my humble opinion, they all should be, every single one, simply because you can gain so much information, particularly in the learning and behavioral realm, about what's going on with that brain. So kind of the quick and dirty, as they say, on brainwave function, you've got your delta, theta, alpha, beta, gamma, all the different brainwaves that we know about and understand, particularly, everything up to gamma. Gamma is the enigma still, but we know enough about it that we can get into some training of gamma activity. But at the end of the day, the way I like to look at it is you look at the slow brain waves, delta and theta. In general, those are inwardly directed brain waves. So when we're more focused on our internal environment, we have more delta and theta activity. Alpha is that conduit between slow and fast. So we're looking at that mid-range 8 to 12 hertz or 8 to 12 cycles per second, whereas delta and theta are anywhere from 1 to 7 hertz. Alpha is that relaxed focus. Most is known about alpha, and that's where when people are meditating and mindfulness practices, they're trying to typically generate more alpha and even high theta type of activity, so they can have more relaxed, focused, in the zone type of attention. Then we get into beta and high beta activity and gamma. So those are the faster brain waves. And faster brain waves, by and large, are more outwardly directed. So when we're focused on our external environment, we're generating more, or we should be generating more beta activity. And I say should be because we see paradoxical effects. Say when somebody has their eyes closed and we're doing a recording, naturally we're more focused on our internal environment with the eyes closed. Now we open the eyes and we should see suppression of certain things like slow wave activity when we open the eyes. But we can see paradoxical effects. When people open their eyes, now they have increased slow wave activity. What's that all about? That gives us information on how to direct treatment. And that could be because now we can correlate between tests, and if their oculomotor functions are significantly disturbed or aberrant, then we understand this is more emphasis needs to be placed on oculomotor rehabilitation, not just trying to do, say, neurofeedback to drive down that slow activity, because that could be a futile effort. And driving down slow activity, which we'll talk about in some of these scenarios, excess slow activity is, at the root of traumatic, particularly things like post-concussion syndrome, even getting into autism, getting into, post-COVID and viral infection influences on the brain fog. So, there are practitioners that do solely neurofeedback, and they will try to drive down the slow activity week after week, month after month, and barely have an impact on it. So we can direct things like eye movement therapies, even a study I did, an in-house clinical study that we did, outcome study, on whole body vibration and EEG activity, we can significantly dampen slow wave activity by getting somebody on a vibration plate.
Yeah.
So we can see all this excess theta, get them on a vibration plate, and we can see that come down. Now they're better prepared for the next activity, be typically more of a cognitive-based activity or a physical slash cognitive type of activity. So it allows us to really drive all types of treatments, not just the treatment that most would expect coming out of EEG or QEEG, which is neurofeedback or some sort of biofeedback.
So when you have a child with autism or ADHD and they are in that, probably autism, they're in those lower brainwaves the whole time, and then you start to stimulate using different stimulus like vibration or using smells, using different coloured lenses, and you start to overlay all that sensory input, what effect does that have on the brainwaves?
Yeah, absolutely. Like I said, even just, we were kind of pulling out therapies like neurofeedback, transcranial laser, doing things individually to see what kind of impact they would have so that we could better prep for the next therapy. But for the most part, like you said, getting into autism, excessive amounts of delta and theta activity, as well as getting into the faster brain waves as well. There's just a significant inward focus where these people can't process a lot of what's coming in from their environment. So, we can certainly set them up better for certain types of rehabilitation by picking and choosing what's going to have the best impact on those brainwaves. Because at the end of the day, most modalities that we utilize are frequency-based modalities: smell, light, sound, vibration. And what is electrical output of the brain? It's frequency-based. We're talking about cycles per second. What's the frequency of those brainwaves? So we can try to, either match or kind of, use other ones to bring, other frequencies to bring up frequencies that might be too low. So, we just want to be able to pick and choose out of the toolbox what's going to, a lot of it comes from clinical wisdom or intuition as well, as going through practice. So, in the beginning, it's harder to, you have to kind of throw a bunch of things at people to see what sticks and trial and error. But we've gotten to the point where we can, most often predict what's going to be the next best thing to do for that person. But it's really, there's so many modalities that can be utilized, and I'm always amazed to learn what people are doing in practice as far as being able to regulate brainwave output, even though they're not measuring.
I mean, that's the most interesting thing. There are very few people who understand how to do the brainwave diagnostics to a level where they can then change the output of that, the outcome of that child or person, because they can go and have a QEEG done, but you never really get to understand what it actually means. And I think that's, I've seen many patients that have got QEEGs done, but they really don't understand the level that they now need to take. So what is the next steps they need to take in order to, because they don't have that level of understanding from the practitioner that took it, to then change those brainwaves and how to then influence and stimulate that. So,
and most QEEG is being done simply to dictate what neurofeedback protocols are going to be utilized for that individual. It's even to the point now, but that was one of my things early on in practice is, why can I help all these people, but I can't help these one or two or five or. And it's really about, our success rates in those outliers has gone up tremendously because we can really understand the nuances in the outliers and work with getting them towards normalization and not just saying, all right, well, we just couldn't help them.
So I get questions from parents a lot, my child's 6 or my child's 10 or my child's 14. With neuroplasticity, can it continuously change, or is there a point in time at certain developmental stages where you get to a point where the white matter, the grey matter's in, and it's harder to change neuroplasticity? I mean, I know the answer, but I'd love you to talk me through it, because I know you're doing this every single day in your clinic.
Yeah, it's one of those things. I remember, way before I started studying anything brain, I was taking a racquetball class, and I was already a pretty darn good racquetball player. That's what they do in the Northeast. They play racquetball. I've been in the South for 20 years. They don't know what racquetball is. They know what pickleball is, not racquetball. But I had an instructor who was probably 70 years old, and he comes out on the court, and he's got bandages on and braces on every joint, and he comes out and he's probably 75, 80 pounds overweight, and he's just standing there. I'm looking at him like, how is this guy going to teach me how to play racquetball? And by the end of that first half hour or so, I was literally sweating and bleeding and running into walls and doing all kinds of things, because he was placing this ball in places that no other human could place them, because he had to adapt for his physical limitations by becoming incredibly skilled at placement.
Yeah.
So he trained his body and brain over time to do what he needed to do to continue to win at those, those high levels over time. So, that was my introduction to neuroplasticity. I'm like, this is just amazing stuff. So, that's the long way to say that, I tell people all the time, our brain is changing and growing for better or for worse. Neuroplasticity has a dark side until we take our last breath. And yes, it certainly does get harder. Systems are much more rigid over time, but change can happen. We are seeing after, especially severe traumatic brain injuries, reemergence of primitive reflexes in people, be it spinal reflexes or rooting reflexes, things like that. And we do see we can make positive change in these things over time. So, yeah, neuroplasticity dictates we will continue to be able to be moldable until we're done.
And with some of those pretty severe injuries, those reflexes do come back. Do they once you've reduced like the inflammation within the body, do you see that they go within? Once you're increasing the amount of energy within the body, you're giving the brain the amount of oxygen, you're using light therapy, you're using all these different modalities.
Yeah, we do see them diminish. There are certain cases. Diffuse axonal injury is the one big example, and hypoxic anoxic brain injuries where, it's going to be pretty tough to get rid of these reflexes, but at least if we can diminish them. This is a person whose nervous system was already organized and developed appropriately for the most part, who had this accident or loss of oxygen or whatever that has created the emergence of these primitive reflexes. And, they can be much, much more difficult, say, than somebody who's had a concussion. And, we can remediate them much faster in those cases. So, yeah, there's kind of a continuum, but they can be quite difficult for sure. We just want to keep on top of them and do whatever we can to suppress them as much as possible.
And with regards to cognitive decline, talk me through pick a patient and talk me through a patient that you have worked very hard with, that has then come through that, whether it's Alzheimer's or Parkinson's, or you've taken them through that and you've suppressed those symptoms, because this is one area that is just not looked at in the UK currently. And the ability to change that trajectory of that person is just life-changing.
Certainly, yeah. There's, the one that comes to mind, and we see so many of those cases. I actually sit on the board of advisors for the Dementia Society of America, because they recognize, a lot of what we're doing, and they're a much more proactive organization than, say, Alzheimer's Association, which is really focused on the cure. It's in the here and now. What can we do, from music therapy to art therapy to, the diagnostics that we're doing? What can we tell about that person's brain, hopefully early enough so that we can possibly see some tide shift and improvements. But if not, just, improve quality of life as best possible in their extended years, which helps not just them, but their caregivers as well. So there was a case I saw. This is a unique case in that this fella, and I've got a paper on it that we actually had published, I can share with you, but it was a fella who's probably about high 60s, maybe 70, and he had radiation to the brain for a benign ependymoma, I believe it was. And the radiation did significant damage to his brain, to his central nervous system, particularly brainstem. They were showing damage to his eighth cranial nerve, balance and vestibular and hearing nerve. So we saw, along with that, his wife called us and basically said, yeah, his balance and everything is bad, but his brain is just it's deteriorating so rapidly. This was a guy that was a high-level man. He was a real estate investor, and he was still managing all of his properties. He was on the golf course every other day. Just very high-level guy. And he went from that to basically staring at the walls in a period of about 4 to 6 weeks or so. And his best friend was also his golfing buddy, was also his primary care physician, basically told him and his wife, said, "You've had a good run, let it go." And that was the answer. And that was coming from, it's painful to hear every time I say that. But what happened, his wife, didn't take no for an answer, and she just kept searching and searching and searching. Did memory care, things like that, and just a little bit of progress here and there. But she finally found us, and we went through a 10-day immersive with him, the physical, the neurological, the cognitive, the metabolic rehabilitation. And we were able to see gains as high as 69% in things like executive function, cognitive flexibility, neurocognition index, which is an overall marker of cognitive abilities, attention focus. But, yes, it's great. We saw the improvements in those cognitive domains, but it also translated into him getting back on the golf course. He did pull back from his work and had somebody take over the management of his properties and all. But he was able to plug back into life when he was pretty much written off. There's just, I love these people that just don't take no for an answer and just continue to push and persevere because they knew something was wrong. And with that, that's different than a typical cognitive decline case where, blood sugar is usually one of the biggest culprits. And even now we're learning, viral infections and dementia and Alzheimer's. So if we're not addressing the metabolic, we are missing the boat in a big way because it's, guilty until proven innocent. I ask people all the time if they're coming in with mild cognitive impairment or full-blown Alzheimer's like dementia that, are there any challenges with blood sugar? Oh, no, that's all good. Okay, let me see the numbers. Then you look at the numbers. There's only a fasting glucose that's been run, and it's about 110, and they've been told, okay, that's normal.
It's normal,
what about,
yeah.
Yeah. What about fasting insulin? What about, what about hemoglobin A1C? What about looking at that blood sugar every day? What about looking at that blood sugar after you eat something? Looking at trends and patterns. But the fact is, all of these people, for the most part, are diabetic or borderline diabetic. And that needs to be addressed because you will never rehab a brain out of small vessel disease.
So when it comes to those patients that you've done testing on and you've seen different viral, different viruses that are in their system, you've done that neural Zoomer Plus test probably, what do you see? What are you seeing in terms of patterns with some of these patients, the types of viruses that they have that is holding them back, that are laying dormant in their system or just causing havoc in that nervous system and the brain?
Yeah, I mean, it's really all over the place. We can certainly, guesstimate what we might see, but, certainly, especially where people are getting into, gait and balance issues, the cerebellum is under attack. We're seeing these anti-Purkinje antibodies, and we have to deal with those things happening because, the cerebellum is critically important for helping us, navigate our physical environment. And, it takes a really good brain to stay on 2 feet. So if somebody can't walk appropriately or they're shuffling or, they're falling, that's directly reflective of their cognitive capacities. They go hand in hand. So we need to address those underlying, viral concerns for sure. But there's also now something we've always looked at, but we're looking at more heavily now is the environmental toxin end of things because, that landmark study just came out on Parkinson's and golf courses. We have, I don't know if you saw that. It was out just a few weeks ago or a couple of months ago. Basically looking at people that live, a mile, 3 miles, and 6 miles from a golf course. And incidence of Parkinson's goes way up if you're within a mile of a golf course because golf courses are the most heavily sprayed and chemically, chemically dealt with types of things. So it used to be if somebody was coming to me from California or rural South Carolina or something like that, we would run environmental toxin panels because everybody lives near a farm. They have planes coming over and spraying. People coming from the coast, they got the mosquito sprayers coming in all the time. So we have to look at, the herbicides and things like that, atrazine and glyphosate and all the other things. We have to look at them. If somebody's coming to us and they've been in the military, even as, back as far as Agent Orange, we can look at those things through some of these tests, components of Agent Orange. So if we're not dealing with those things, we're not addressing the neurotoxic chemicals that are likely causing these problems, or at least significantly, heavily contributing to them.
So when I treat patients in clinic and they've had different testing done, whether it would be viral or whether it would be mold testing or any heavy metal testing, and we start to really look at the load in that child, those are the things, if you're not dealing with that as well as the treatment of the brain, the cerebellum, those are the things, and actually working on those reflexes, which is always exceptionally important to get them to inhibit, to bring those frontal lobes down. It's really, really significant in terms of the change when you start to detox the body, you start to detox that liver, their kidneys, and you're really starting to get those elements out of the body that really shouldn't be there. The change that we're seeing just in those children in weeks is significant.
Absolutely. Yeah, and that's where, the best of both worlds. I remember kind of growing up in this, this healthcare thing that I'm in right now. And, I was clearly heavily brain influenced. Most of my neurology studies started before I left school and continued till present day, and everything was brain. And then I'd go to functional medicine seminars, way back with Jeffrey Bland and some of the, the bright minds, that really got functional medicine on the map, and everything was gut. And I'm like, all right, I've been one to sit on the fence pretty much everything I do, so I can see on both sides what's happening. And, you have to look, and even reading books 20 years ago, The Second Brain by Michael Gershon and others that, just really made me believe and understand that you have to deal with these things. You have to come from every angle to deal with this, because yes, functional medicine practitioners solely are, seeing great results in practice. Yes, neurofeedback practitioners solely are seeing great results in practice. Yes, functional neurology practitioners solely practicing functional neurology are seeing great results. But when you start bringing together the best of all worlds, that's really where the sky's the limit.
Yeah, you start getting the healing process is just so much faster. And I think,
and order of operations too, we've become, the last 5 to 10 years, I've really been focusing more on order of operations, what needs to be done first, how can we continue to make what we're doing better? And that really seems to be the biggest part of the equation right now, is doing things in succession in an appropriate manner for the best outcomes in the shortest period of time, especially when time is of the essence in something like dementia. So, what we're doing now is even consulting with people. If somebody calls me from, Michigan, and, it's going to be a few weeks before they get in, then what we do is we run the labs. We do all we can up front to deal with that. Sometimes, we can't do it that way. People have to get in, whatever it is. They only have summer to do it, and they've got to get in, and we can work those things concurrently. But, we typically want to deal with the metabolic issues first.
Yeah. I mean, there are many children that I see that do have metabolic issues with that global delay, and that really hasn't, been the case that they've looked into previously. So I had a parent on the phone last night, and I said, for more global delay, you need to really start looking at metabolic issues. And the parents were like, but her diet's fine. And, and you're like, but maybe you should look at them. It's difficult because, you're in a position where you have information that you want to share, and it is, sometimes it's difficult for parents to really understand, but, this is a brain thing. Well, no, you need to look at the whole body. It needs to be looked at as a whole, and gut health is exceptionally important. So, yeah.
Absolutely. Yeah, and that too, and that's, I'm glad you bring that up because that is one of the biggest things is, dealing with the family, the caregivers. It's so critically important because, like you said, the diet's fine. Well, define fine, like what is fine? Not you, but them. We had a family in 2 weeks ago, and, by all accounts, their diet was fine. They were eating well, and, right here in our facility, they would bring in, I don't know if you have Bojangles in the UK, but, they would bring in a bag of Bojangles with a 32-ounce sweet tea because we're in the South and everybody drinks sweet tea in the South.
Yeah.
And, there's no way you're going to power a brain effectively with 32 ounces of sweet tea. It's just not going to happen.
Yeah.
Yeah.
Yeah, I had a patient in eating rice cakes, chocolate, and you want to be able to do the best whilst you're in clinic. And it's really to ensure that you have the most amount of attention with that child during that period of time. And you want them to be in with you as well. And I think it comes down to there needs to be that awareness, and a lot of it does get to the point of diet and understanding. And I work with an incredible functional nutritionalist who really does help there and do all of the labs to really having that true deep understanding of what's going on inside your child really then takes you to that next level because you can understand what you need to do in order to influence it. And that diet, once you start reducing the inflammation and reducing the sugar and, all of reducing the oxalates and the clostridia and all of those things that really, have a huge effect on a child, and thinking about, nasal washes, and if you've been exposed to mold, and looking at all of those different areas has a tremendous effect just on the function of that child to then be able to do much more effective therapy. And it does all work hand in hand.
Absolutely.
Yeah.
Absolutely.
It's been such an amazing session with you. I am really grateful that you jumped on. There were so many gems in there, and I'd love that paper. You mentioned a couple of papers so that we could share it with the listeners in the notes when I put it online. And
Sure.
I'm very grateful to you. Thank you so much. Maybe we'll do another session and jump into some QEEGs to give the listeners a good understanding of what you can really see and how you take things forward with an understanding of what their QEEG is.
Yeah, I would love to. And also, just as a reference for the listeners, there's an organization. I actually was I sit on the board for several years, and was just yesterday was nominated as president-elect of the International Society of Neuroregulation and Research, and it's really the public-facing entity for all things EEG and neurofeedback. So people just want to start to begin to understand what is this? What's it all about? We have a really robust website and bibliography, looking at all the things from, A to Z conditions and all the research related to all of those things with regard to EEG and neurofeedback. Even if you don't have equipment, even if you're not recording EEGs and doing neurofeedback, at least it can start to give you an understanding and be able to communicate with the providers you're working with to understand what they're doing. So if somebody sends somebody in and they have a QEEG, well, it might be nice, like with labs or something, to know a little bit about it. So it really is a tremendous resource just to get involved with, and there's just a wealth of information, some webinars, and they have I think they call it, it's ISNR education, so you can purchase webinars on things that are of interest to you. But highly recommend it. It's not self-serving in any way, but really just want to get that out there because, again, our people, our colleagues, we need to be looking at this stuff.
Yeah, thanks so much for sharing that, and congratulations on your presidency. That's fantastic news.
Soon, yeah. It's all about work-life balance, and I keep taking on more than I can do, but it's stuff I love, and it keeps me going.
Thanks again.